Yes,
we
we need to
start
get
we
that message out.
start yes, we start the countdown, as you will, as well. Well, we're right at noon, so I'm going to go ahead and start. Welcome to our Roy Benke Department of Internal Medicine Grand Rounds on another Thursday, which is absolutely great weather for this talk. For those excited about your NCAA teams, you got to hold off for an hour and focus on internal medicine education for 1 hour. And then obviously you got to see your patients in the afternoon, but that's when maybe if you get a break, you can check in on how your favorite NCAA team is doing. A reminder, in 2 weeks, we're going to have a very special grand round. So we're going to have a series of reminders because we have a international expert in mastocytosis, Dr. Aiken, coming from the University of Michigan at Ann Arbor. So grand rounds will be held at 8 a.m. That's right, 8 a.m. special edition of grand rounds in 2 weeks at the Valdez Auditorium. Hopefully, all division directors have been planning on which of their staff there will be able to attend. I will work with the hospitalist, pulmonologist, cardiologist of TGH, and with Dr. Aller with the internal medicine residency to make sure we have a very respectable type of international expected crowd for an international speaker. So please keep focusing. April 3rd, Thursday, one of those days you set the alarm clock 90 minutes earlier than usual because we have an incredible speaker and we will have breakfast there. For today, we have a really exciting speaker. She joined our faculty just 6 months ago in the Division of General Internal Medicine under Dr. Jen Shiroki, who continues doing a great job leading the General Internal Medicine Division. We have Dr. Sarah Burbank here. Dr. Burbank is a graduate of the University of Notre Dame, the Fighting Irish, and then after that, she went to Rush Medical College, which owns tons of internal medicine Osler Cup Jeopardy championships. So she was amongst the Jeopardy champions of Rush for her medical school, and then joined internal medicine residency at the University of California at San Francisco, maybe foreshadowing coming to USF with starting to get the letters there. While at UCSF, she was an outstanding internal medicine resident, went on to become a VA Patient Safety Quality Improvement Fellow, which is very near and dear to my heart, given Alex Rice and I helped to establish one of the first Patient Safety Quality Improvement Fellowships in the country back in 2009, which is now shepherded by Elizabeth Melzer. This is our second speaker. If you remember, Chris Jackson was a Patient Safety Quality Improvement Fellowship graduate from Emory. So we have now our second said speaker, and our Patient Safety Quality Improvement Fellowships residents at USF will speak in May for Grand Round. So I love the constant tie-in here with patient safety quality improvement. And after completing her fellowship, Dr. Burbank went for another fellowship at UCSF in primary care addiction medicine. Dr. Burbank has already 21 presentations at a national or local regional level in her 6-month faculty career. She did a lot during her fellowship and her residency and medical school. Already is on her way with almost double-digit publications. Truly, we are very, very delighted and blessed to have Dr. Burbank as one of our newest members of our Department of Internal Medicine faculty. She will talk today on updates and opioid use disorder. And again, Dr. Burbank, a very hearty welcome from me as vice chair to our Department of Internal Medicine. And again, best wishes from Dr. Mosley, who's on vacation for today's talk. And take it away, Sarah.
Awesome. Thank you, Dr. Lizama, for that really wonderful introduction. I'm really happy to be here at USF and to be here today to speak to you about a topic that I'm really passionate about and is near and dear to my heart. And I hope after our time together, you feel more comfortable taking care of patients who use opioids and drugs. So the title of our talk today is Updates in Opioid Use Disorder, Current Trends, Treatment Strategies, and Harm Reduction Approaches. Our learning objectives, I hope after our time together, you feel more comfortable describing trends in opioid use disorder and the role of fentanyl in our current opioid epidemic, reviewing the role of medications and talking to patients about medications for opioid use disorder and how they really save lives, and then recognize key principles of harm reduction and how they can be incorporated into our day-to-day patient care. I don't have any financial disclosures and won't be discussing any off-label use of medications. So just to kind of frame our conversation and give a historical look and kind of catch us up to where we are today, we are currently experiencing the third and fourth waves of opioid overdose deaths. This epidemic began in the 1990s with prescription opioids, transitioned in the 2010s to heroin, and then really where we are today began with fentanyl analogs and synthetic opioids, started in the mid 2010s, kind of mid to late 2015, 2017, 2019, which is when we saw really the street opioid supply switch from heroin to predominantly fentanyl. And then more recently, we're experiencing both a rise in fentanyl overdoses and overdoses involving both stimulants and opioids, which we'll talk a little bit more about. So just as a review, fentanyl is 50 times more potent than heroin and is really driving overdose deaths. Fentanyl that is made outside of the pharmaceutical landscape is typically sold, it can be sold in a few different ways. Here you can see a photo of powdered chunks. This is from an ethnographic study done in San Francisco. And then can also be sold as pressed pills or really basically any type of form. So you can see here on the right a photo from the DEA, pharmaceutically sourced oxycodone tablets on the top left, and then on the bottom right you can see pressed tablets containing illicitly manufactured fentanyl, and they're really pretty similar. Fentanyl can also be found in non-opioid street drugs, which is really dangerous for our folks who are using drugs, and especially those who aren't intending to use opioids and don't have any opioid tolerance. So here's an example from the DEA of a pharmaceutically sourced alprazolam or Xanax tablet, and then a fake alprazolam or Xanax tablet on the right, oftentimes which may contain fentanyl analogs. And then recent data coming out kind of looking at the question of why are there so many overdoses that are rising amongst people who use stimulants. This was a study of patients who used methamphetamine out of California. And 22% of these patients, these are all participants who said they were not using fentanyl intentionally, and yet 22% of their hair samples, which is a pretty good reliable drug testing for fentanyl, 22% had fentanyl in their hair samples, again, which is really concerning and kind of adds to the picture of why we are seeing a rise in overdoses in this patient population. Bringing in some local data, we can see that this is from the medical examiner's office. You can see for the state of Florida what substances were reported in overdose deaths, and you can see fentanyl really being very high, kind of right after alcohol. But we do have some good news from the 2023 Medical Examiner Commission's annual report that compared to 2022, the total drug-related deaths and opioid-related deaths did decrease by 7% and 11% respectively. And this is reflected kind of in national trends as well. Some thoughts about why this may be is increased distribution of naloxone, which we'll talk about later in the presentation, as well as increased access to medications for opioid use disorder. And with that, we've kind of summarized some of the trends. I think the main learning point to take home is that fentanyl is the predominant street opioid and is really highly potent. And we're seeing, again, a very stark rise in fentanyl overdoses. And next, we'll transition to talking about treatment for opioid use disorder and kind of updates for 2025. But before we dive into that, I do want to take some time to review how important it is the way we communicate and the way we talk about patients. We know people who use drugs face a tremendous amount of stigma when they come into healthcare, which leads to poor outcomes in many different ways. It leads to delayed presentations of care. And so I want to give you some tools you can bring into your future encounters when you're caring for patients who use drugs. And specifically first around language. So first, I recommend using person-first language. I recommend avoid using the terms drug abuser or addict, and instead use person who uses drugs or person with an alcohol use disorder with an opioid use disorder. Next, as I think with all kind of disciplines, I recommend using medically accurate terminology. So for example, in diagnostic testing, we often order toxicology. Sometimes these are results are described as a clean or a dirty urine. I recommend documenting the results as urine negative for cocaine, positive for opioids, or whatever the substances are. And then the next term is around diagnostic terminology. The term abuse is really outdated terminology from the DSM-4. And in the DSM-5 criteria, we really want to use like substance use disorder. So you can characterize that substance use disorder as mild, moderate, or severe, which we'll talk about in just a moment. And then you can also add the qualifier: is it active or in early or sustained remission? I think our EMR is still catching up to this because there's a lot of diagnostic codes and billing codes that uses out-of-date terminology, and I really encourage you when you encounter that outdated terminology to update that in the medical chart, update the problem list, or update their one-liner. And then I also recommend using strength-based language. We know that the language we document for our patients follows them through every encounter, can really frame future encounters when they come into contact with our healthcare system. So for example, instead of documenting patient is non-compliant, you can document like the barriers they're facing. You know, they're facing barriers to accessing their buprenorphine every day. And then instead of like saying, oh, they're still using, you can say something, well, they've met their goal of reducing use from 10 times a day to once a day. And these are just some examples. Further updating our terminology, I want to share that the word addiction refers to, and we think about addiction as a treatable chronic medical disease involving complex interactions, including neurobiology, genetics, the environment, and an individual's life experiences. And while it's very intersectional, we do still think of addiction as a chronic disease that we manage just like any other chronic disease that requires regular follow-up and medications. The medical term for an addiction is a substance use disorder, as defined by the DSM-5 criteria, which we'll go into in just a moment. Other updated terminology to share today is that I think we all trained in medical school. A lot of us trained in learned the phrase MAT, or medication-assisted treatment. However, and we'll get to the data on this in a moment, this implies that medications are not the treatment, but only assisting treatment, when really that's not true. We know that medications themselves are really improve mortality and are the core treatment for substance use disorders. So instead, for opioid use disorder, the current guidelines recommend referring to pharmacotherapy as medication for the substance use disorder. So you might see MOUD or MAUD documented for medication for alcohol use disorder, for example. The term MAT is still used very, very broadly in legal terms and in policies. And so when you read MAT, you can also read it as medication as treatment. Again, we're getting rid of that assisted treatment term. And then one more update, just to remind ourselves, I think sometimes it can be confusing, the term opiate versus opioid, and those might be used interchangeably when really we should be diagnostically accurate when using these terms. So opiate refers to the naturally occurring alkaloid components from the poppy plant, and so that does include morphine and codeine. While opioid refers to all compounds, so whether those are synthetic, whether they're naturally derived, that bind to and activate opioid receptors, mu, delta, kappa, etc. So really, we should be using opioid unless we really want to be referring to, for example, the opiate screen on the immunoassay that is specifically going for that naturally derived compound. To round out our review, how do we diagnose opioid use disorder? We go back to for all substance use disorders, the DSM-5 criteria. So you want to run through kind of these different criteria and assess if this patient, for the patient in front of you, if how their opioid use or substance use has affected their life in the last year. And so the different categories we're looking at are risky use. So for example, continuing to use despite having an overdose before, or continuing to inject despite having endocarditis before. So social problems, so not showing up to work or losing their job because of their substance use. Spending a lot of time like giving up the things that they used to love to do, for example, like hobbies or other ways they used to spend their time. Impaired control, so really asking, have you, talking to the patient, are you using more than you intended to? Have you tried to cut down and had trouble doing so in the past? Do you have cravings? Do you have are you thinking about the next time you're going to use, and how does that impact your life? And then lastly, assessing for the physical dependence components of a use disorder, which are withdrawal and tolerance. Key points here are that these two do not count if the opioid is prescribed, since we anticipate that's just part of prescribing an opioid. With time, people will develop symptoms of withdrawal if they stop, and then tolerance, meaning needing higher doses of the substance get the same effect. So to meet criteria for an opioid use disorder, you need 2 to 3 to meet mild, 4 and 5 to meet moderate, and 6+ to meet severe. I would say for a lot of our patients, the most common category I see and take care of in clinic and the hospital are patients with a severe opioid use disorder. And I think it can kind of be intimidating to ask people about their substance use. And so I just wanted to share some language or kind of example questions you might consider incorporating. Motivational interviewing is such a core skill as an addiction provider. So I like focusing up front on open-ended questions. These types of questions really center the patient's narrative and kind of let them tell you their story, their journey, their history with addiction. So I often open up with, let's start by telling me about your relationship with opioids. Tell me how things started and catch me up to where we are today. And just in that simple 1 or 2 sentences, I'll get kind of their whole, all of the DSM-5 criteria that I need. I also like to ask, why do you use opioids? And knowing, for example, if it's oftentimes either for chronic pain, which helps me determine what our treatment course is going to be like, untreated mental health, these things are helpful to know. And then lastly, most people have had an experience with treatment for their substance use disorder. So hearing of their prior experiences will definitely help kind of frame your future conversations. Using that MI framework, some closed-ended questions I often will follow up with and are helpful to ask about. It's really like how much they're using. So when you use, what do you use? Is it heroin? Is it fentanyl? Is it pressed pills? How much do you use? How often? This is helpful to predict. It's not precisely predictive of tolerance, but can be helpful, especially when a patient's coming into the hospital, so you can kind of get to know what their opioid needs while being in the hospital might be. And then I do like to ask about route of administration, or when you use, how do you use? So whether that's intravenously, smoking, which I would document as inhalational use, snorting, I would document as intranasal use. All of these things, like routes of administration, come with different medical comorbidities, so helpful to know that as well. And now moving to medications for opioid use disorder. There are 3 FDA-approved medications for opioid use disorder: methadone, buprenorphine, and naltrexone. My question to you is, how well do buprenorphine and methadone work? And the answer is very well. Multiple studies and meta-analyses have shown just how effective specifically buprenorphine and methadone are for reducing mortality and overdose prevention risk. 50%. When we think about all the things we do in medicine, it's just really awesome that we have these medications and they're such a life-saving intervention. They are also the only interventions associated with reduction in overdose compared to no treatment. So basically, this was a comparative effectiveness trial where using claims data, de-identified claims data, and the authors looked at the treatment and then overdose risk at 3 months and 12 months. And really, buprenorphine or methadone was the only statistically significant intervention that reduced folks' risk of overdose compared to naltrexone, compared to behavioral health, intensive outpatient, inpatient services, and other forms of kind of psychosocial support. So my next question for you to think about as we go through this is, how do you decide what to recommend for a patient, buprenorphine versus methadone? Really, the answer is that the patient decides. These two medications, we'll go into the details in just a minute, are delivered in very different treatment settings. And most patients with an opioid use disorder have experience with both, and they'll know which is kind of going to work best for their lifestyle and work best for them to meet their needs or their goals around their substance use. However, when you're meeting someone who maybe has a new diagnosis of an opioid use disorder or has never accessed treatment before, it is helpful to know a little bit of the nitty-gritty so you can kind of guide the conversation on which might be best for them. From a pharmacological standpoint, both methadone and buprenorphine are opioid agonists, while naltrexone is an antagonist. Methadone is a full agonist, just like fentanyl, oxycodone, morphine. Those are all full agonists. Buprenorphine is a partial agonist, which is special. That means that as you get more and more doses of buprenorphine on board, you have there's a ceiling effect, and so you have a little to no risk of respiratory depression, which makes buprenorphine a very safe medication to prescribe. Both methadone and buprenorphine have long half-lives, which is why I'll use the half-life when I'm talking to patients and they're asking, well, aren't I just substituting one addiction for another if I get on a medication? And I'll say, well, no, like these medications, the way they work in your body, they're going to take care of withdrawal and cravings for a long time. And you're not going to have that kind of quick on, quick off, thinking about cravings, thinking about your next use, just because of the way the medication works in your body. And then I'll mention buprenorphine has a very high binding affinity. It's very sticky. So it will, when it encounters a mu opioid receptor, it will kick off anything else that's in that receptor. And that's what leads to the high risk of precipitated withdrawal, which we'll get into just a minute about how we mitigate that risk. I think the biggest difference when we're talking to patients between methadone and buprenorphine is the treatment setting. As we're all familiar with, methadone can only be given by federal regulation in an opioid treatment program, whereas buprenorphine can be prescribed from really any treatment setting. And we'll get to the changing laws around buprenorphine prescription and the removal of the X waiver in just a bit. And the last advantage I'll mention to methadone is that you don't have that risk of precipitated withdrawal with methadone, which is why in the hospital it's such a great medication, because we can give it even within a day of their last fentanyl use, knowing whereas with buprenorphine you again have that risk of precipitated withdrawal. Just want to update everyone on all of the different buprenorphine formulations we have available to us in 2025. We have 2 indications for buprenorphine. So there are formulations I won't talk about today for chronic pain. So those include a patch and the buccal films. The FDA-approved medications or FDA-approved formulations of buprenorphine for OUD include sublingual, intravenous, and then extended release subcutaneous, which really exciting. We have a new form I'll mention in just a moment. And then in the sublingual formulations, again, we have both tablets and films, and dosing can be up to 32 milligrams a day. And there's also IV buprenorphine, which other hospitals have used inpatient and is also a great tool when you're on the inpatient side. Brixadi is the brand name for a new form of extended release buprenorphine. So this is either a once a week or once a month injection that patients can get. And the prior form of extended release buprenorphine that we also have available to us is called Sublocade, which has a very big needle and is pretty uncomfortable to get. this new formulation is really exciting. It's much more patient-centered in terms of the administration. And there are lots of exciting new what we call direct to inject protocols, where patients actually don't need to be stabilized on sublingual before they need to go directly or we can go directly to the weekly and then monthly formulation. And there's also a lower risk of precipitated withdrawal when starting because of the pharmacokinetics, the extended release buprenorphine. We're working really hard in Health Park to get Brixadi here. Right now it's only through certain specialty pharmacies, but I think more to come. And I think we will probably see in the next few years lots of patients on extended release buprenorphine, hopefully with a direct to inject protocol. It is on the Medicaid formulary. And just to review buprenorphine starts, I mentioned this risk of precipitated withdrawal, and I mentioned how fentanyl complicates that a few times. So in what we call a traditional buprenorphine start, we tell the patient just wait. You'll need to wait, stop using your heroin or oxycodone or whatever that full agonist is. Wait until you're in withdrawal, 8, 12, 16 hours. Let that full agonist kind of empty from the opioid receptors. Then we give buprenorphine, and the patient pretty quickly achieves relief and feels a lot better. The difficulty with fentanyl is that it's a very lipophilic drug. That's why it's so good to use in the ICU or in the emergency room. It crosses the blood-brain barrier so quickly. However, when patients use fentanyl chronically, they actually can build up fentanyl in their adipose tissue, and it starts to have the pharmacokinetics more of a long-acting opioid, and so can be kind of hanging around in someone's system a long time. So patients for this quote-unquote traditional buprenorphine start, they really need to wait 24, 48, even 72 hours after their last fentanyl use to be able to take buprenorphine without that risk of precipitated withdrawal, which is pretty tough for some patients. So we can see this patient has waited the same amount of time. They're starting to feel withdrawal symptoms, but they have a lot of fentanyl on board. The buprenorphine comes in and they have worse or precipitated opioid withdrawal. So all this to say that in the era of fentanyl, buprenorphine inductions are absolutely evolving. I think our first line is still trying this traditional approach, but there are also other protocols we can try. So one type of protocol is called microdosing, where a patient overlaps whatever their opioid of choice has been, and they overlap that with slowly increasing doses of buprenorphine over the course of 3 or 7 days. And there are protocols that most of this is kind of case series level data and some retrospective reviews. There are both inpatient and outpatient protocols that have been looked at. Macrodosing is another option where patients essentially have stopped their drug of choice and then they get a large dose, like up to 24 milligrams in a few hours of buprenorphine. That's typically done in the emergency department by our EM colleagues.
Overactivity of the parent power plant.
Next update I wanted to share for 2025 is what we should be doing with acute pain and in the perioperative setting. So a multidisciplinary expert panel now agrees that buprenorphine should not be routinely discontinued during the perioperative period, and that a temporary dose increase of buprenorphine may be needed, or it's also okay to prescribe with proper counseling and expectations, additional full agonists, which as long as the buprenorphine is already on board, there's no risk of precipitated withdrawal if you're adding additional full agonists on top of that. It's really the other way, having the full agonist and no buprenorphine on board, that's where the precipitated withdrawal comes. California, I wanted to share this protocol from California Bridge. They are a really awesome consortium of addiction medicine doctors in California that have all free protocols online. So I definitely recommend them as a resource. This is their kind of framework for addressing acute pain management in patients on buprenorphine and their stepwise approach. So they recommend continuing maintenance buprenorphine, whatever the patient previously was on. You can consider, if they were on daily dosing, doing split dosing. And then because of that can be helpful for analgesia. Using multimodal non-opioid analgesia, so other forms of medications, Tylenol, ibuprofen, gabapentinoids, and then depending on your level of care, and ketamine, etc. And then lastly, additional opioids. So you can either dose more buprenorphine up to 24 to 32 milligrams a day, or give, again, full agonists on top of that. Next update in buprenorphine I wanted to share is that the X waiver is now gone. So now what? So just as a reminder, the Data 2000 law was the law that put into place the X waiver that was like basically an extra training that was required to be able to prescribe buprenorphine. This law also had in place kind of different rules around like a panel of patients and how many patients you could prescribe buprenorphine longitudinally at a time. It was quite confusing. Now that has been removed as of 2023. So now anyone with a DEA can prescribe buprenorphine. So if you can prescribe oxycodone, you can now prescribe buprenorphine, which is really exciting. Now, just moving forward, when you renew your DEA, the new requirement is you need to have 8 hours of training on kind of any substance use, on opioid use disorder or substance use disorders, in like kind of a CME setting. While this is all great news, I think the not so great news is that, at least at looking at a study from last year, has this led to increasing access or increasing buprenorphine prescribing? Not quite yet, which I think really speaks to all of the different barriers to treating opioid use disorder, and kind of continued education that is needed for providers. Next, I wanted to share updates in the role of urine drug screen, which we often order for patients on buprenorphine. Why do we do this? Kind of for two different reasons. First, we want to confirm the patient's taking the medicine. We want to confirm that the treatment we're prescribing is getting into the patient's body. I think about it similar as to when we prescribe a statin, we check a lipid panel. We want to make sure that the medication we're prescribing is getting into them. And a lot of times our first step when the lipid panel comes back not controlled, we want to assess like, oh, like, are you taking your statin? And that this is kind of a similar thought. And then we also want to support the patient in achieving the kind of their overall substance use goals, both around opioid use and non-opioid use as well. So how do we interpret the urine drug screen for patients on buprenorphine? First, I want to share that the urine drug screen is a screening test. It is not a confirmatory test. And so if we have any questions or like the result was not what we expected, oftentimes the next step is either repeating the sample or sending it off for mass spectrometry-based confirmatory testing, because the urine drug screen is like, again, a screening immunoassay. I'll point out that the point of care urine drug screens we have do not have fentanyl, because the fentanyl point of care test, there's not a great FDA approved one just yet. So that's important to know. So what do you do when you get a result that you weren't expecting? I think first the main theme here you can see is that buprenorphine really should never be stopped solely based on the urine drug screen results. We know from multiple studies that buprenorphine has a protective effect against overdose, and when you take that away, you're really harming the patient and increasing their risk for overdose. And so if it's negative for buprenorphine, you really want to talk with the patient and really kind of figure out what's going on with the patient and kind of get a sense of diversion risk. If it's positive for other opioids, that means that, your opioid use disorder is not quite under control yet. Like, how else can we help you? Should we increase the buprenorphine? Should we switch to a different formulation of buprenorphine, or should we consider methadone? And then if the urine drug screen is positive for other substances, it's really asking about, okay, how can we help you with your stimulant use disorder? Okay, I see benzos. Were you prescribed benzos from someone else? Do you have a benzo use disorder? How can we support you with that? And I just wanted to put a plug for where patients can get buprenorphine. In our USF TGH system, they can come to our Health Park clinic. We've had a clinic here since 2019 for buprenorphine prescribing. It was previously called Suboxone Clinic. We've kind of rebranded to be the Health Park Outpatient Positive Change Clinic. And we offer both substance use disorder care, so kind of like a broadly addiction medicine care, as well as primary care services for people who use drugs and alcohol. We don't yet have an EPIC referral that is being built. if you have a patient who you think would benefit from being seen in our clinic, you can message me for now. And we also have drop-in appointments on Tuesday. We're really hoping to be the lowest of barriers of an addiction medicine clinic. And then to wrap up this section on medications for opioid use disorder, I would be remiss if we didn't talk a little bit about methadone, which again, we cannot prescribe for opioid use disorder in the outpatient setting. It can only be dispensed in an opioid treatment program. Inpatient, you can use methadone, that it kind of falls outside of, not like under those federal regulations. So just some pearls I have around methadone. First, for admission and discharge, really, I recommend communicating with the OTP, like getting on the phone, calling, confirming their dose, confirming when their last dose was, have they had any dose increases recently, and when the patient is discharged, really be mindful of weekend discharges. A lot of times, if the patient doesn't have take-homes, they need to dose over the weekend there, and sometimes they're not open, or a lot of times it will be like a brand new intake for the patient if they were in the hospital and missed doses. So just be mindful for folks who are on methadone of weekend discharges. Asking patients about take-homes. So take-homes mean that they're like doses of the liquid methadone that the clinic gives to the patient often once a patient is stable. So asking a patient if they have take-homes is a good way to figure out how stable they are with their opioid use disorder. Lastly, methadone for opioid use disorder is not prescribed. As I mentioned, it's only dispensed at the OTP, so it won't show up on the PDMP unless it's prescribed for chronic pain. And then I mentioned also, as with buprenorphine, same with methadone for acute pain, really recommend multimodal pain medications. And especially in the inpatient setting, okay to give additional full agonist as needed with proper monitoring. And with that, we've really talked about the truly life-saving medications of buprenorphine and methadone. So I want to spend some time next talking about harm reduction. So what is harm reduction? There are so many different definitions out there. I really like this illustration from the National Harm Reduction Coalition that kind of speaks to the intersectionality of harm reduction both as a social justice movement and kind of a practical approach. I think of harm reduction as a practical set of strategies that people who use drugs can use to reduce the harms of their substance use. And we'll talk about what does that actually mean in just a minute. Two key principles I really like from the National Harm Reduction Coalition, I just want to read out loud here to share with you all. So harm reduction understands drug use as a complex, multifaceted phenomenon that encompasses a continuum of behaviors from severe use to total abstinence, and acknowledges that some ways of using drugs are clearly safer than others, and affirms people who use drugs themselves as the primary agents of reducing the harms of their drug use, and seeks to empower people who use drugs to share information and support each other in strategies which meet their actual conditions of use. So I think I want to speak here that harm reduction is not something that came from within the medical institution and not something we as healthcare providers feel like we need to be experts on our own. Harm reduction came out of the community of people who use drugs, specifically in the HIV/AIDS epidemic. Folks who use drugs noticed that they were having HIV, and the government, the leadership was not listening to them, and so they found ways to keep themselves safe, including bleach with needles and kind of other ways to prevent their community from dying. So this is really a movement that started outside the medical system, but that we should be aware of as healthcare providers who care for patients who use drugs. So I think the first harm reduction strategy we are in medicine are most familiar with is Narcan or naloxone. It's truly life-saving during an opioid overdose. This medication is intended for a bystander opioid overdose reversal. So I tell patients when I give them naloxone, this isn't meant to be used on yourself. If you're having an overdose, you really need to have someone with you, or tell the people who are in your house or the people that you're around that you have about the Narcan that you have. Narcan being the brand name for the intranasal naloxone spray. And really exciting, in 2023, FDA approved intranasal naloxone for over-the-counter use. It is a little bit cost prohibitive now. Right now, it's about $50 for a 2-pack at like your kind of local pharmacy. We do have Narcan available for free at the Syringe Services Program, which I'll mention in just a moment, and also here at Hope Clinic. So just to review the current guidelines on who should be offered naloxone. So from the 2022 CDC guidelines for chronic prescribing of opioids, anyone who's prescribed chronic opioids, especially those at high risk, should have naloxone. Those at high risk includes folks with a history of an overdose, who are on high doses of full agonist opioids, of daily morphine equivalents of greater than 50, if they're co-prescribed with a benzodiazepine, if they have a history of substance use disorder, and then if they have sleep disordered breathing. And I'll add that even if the naloxone is, or even if the opioid is not prescribed by you in like primary care or your specialty clinic, you can still prescribe the naloxone. It doesn't have to be from the prescriber of the opioids. And then I also recommend that naloxone be prescribed to anyone who uses any type of street drug or who are around people who use. So even if they just use methamphetamines, for example, we saw kind of from the epidemiological data that we have coming out now, that those patients with the unpredictable drug supply are still at risk of overdose. And so I recommend Narcan to anyone, not just folks who are intending to use, anyone who uses any type of street drug. And overdose prevention really goes beyond naloxone, which is the intervention we are most familiar with. So some other strategies that I talk to patients about are first about using with others. Using with others so that if you are in an overdose, you can get life-saving help. Next, if you have, especially if a patient is trying something new for the first time or from a new supplier, I recommend them take a test dose to make sure that it's not too potent and won't lead to an overdose. I tell people to especially proceed with caution if they're going to use after a period of time when their tolerance is down. So for example, after hospitalization or after they're coming out of incarceration or jail. Another strategy that patients can use are fentanyl test strips. These are little test strips that are available. We have them at the exchange, but you can also buy them on Amazon for like $1 a strip. And essentially the patient dissolves a little bit of the drug they're intending to use, and then takes a test strip, and it's like 2 lines, 1 line, just like using like a pregnancy test or a COVID test, and it will tell them if there's fentanyl in the substance they're intending to use. And then lastly, a resource I give out is the Never Use Alone hotline, which is a 24/7 staffed hotline for people who need to use but don't have anyone around them. And an operator will answer the phone. They'll be on the phone with them while they're using, and if the person stops responding, they'll call EMS and get them help in the case of an overdose. And there was a really great, I'll just put a plug in, there's a really great This American Life episode about this hotline and kind of the lives that have been saved from this intervention. And then lastly, harm reduction goes beyond overdose prevention, which goes beyond just Narcan. There are lots of different ways that harm reduction can be incorporated into patient care. One is referral to community harm reduction programs for safer use supply. So that's like clean needles, needle exchange programs. Condoms, PrEP, PEP, those are all forms of harm reduction, as well as HIV and Hep C testing for our patients who are at risk. And then one more intervention I'll mention that has been looked at in the medical literature is supervised consumption sites, or places where people can go to use and be monitored for an overdose. Those have been studied in Canada and Australia and other countries, but are not yet legal in the U.S. So where locally can patients get harm reduction services? We have our IDEA Syringe Services program. It's a mobile van, comes to Health Park on Mondays and Fridays, and then in the Ybor City neighborhood on Tuesday evenings, as well as out in Brandon. And we offer Hep C, HIV testing, harm reduction supplies, as well as buprenorphine prescriptions, and which I think are particularly important for our unfunded patient population, so we can see patients regardless of their insurance status. And with that, we have wrapped up our key principles of harm reduction. So some take-home points I'd like to share, and then I'm happy to answer any questions, are first that we really are in an overdose crisis, primarily driven by fentanyl. Patient first, medically accurate language will reduce stigma and improve patient care. Medications for opioid use disorder are very safe, very effective, and we should be working to increase access to medications for opioid use disorder. And lastly, harm reduction meets people where they are and saves lives. Here's the list of references for the presentation. I just want to say thank you to Dr. Shiroki Kochavi, who our wonderful Division of General Internal Medicine leader, Dr. Asa Oxner, who's currently out on leave, but a mentor for me, and the medical director of our syringe services program. And with that, I would love to take any questions, and I'm really honored to be here today.
Thank you very much. Outstanding presentation. So we'll take, and I agree, excellent mentors with Dr. Shiroki and Dr. Oxner. All right, any questions from folks? And we'll check the chat. Jen always keeps an eye on the chat for me.
Hello, my name is
We have the CME code there for folks to not forget.
Can you hear me?
Yes,
Oh, yes,
I can
go
hear
ahead.
you.
Oh, okay. I'm the palliative care physician in the Brandon Healthplex, and mostly we're seeing the cancer-related pain. Of course, you know, most of my patients taking the morphine equivalent dose is, I think it's more than 100 milligrams. Most of people, but unless they request, I haven't prescribed the naloxone yet. But do you suggest that it will be safer? In my personal experience for the last 20 years, I didn't feel like I have any issue with the life-threatening overdose issue. It could be a little bit, the slowly design, some toxicity, but I was able to handle. So I personally didn't feel like you need it, but I just wanna
Yeah.
hear your opinion.
Yeah, that's such a good question. So the recommendations for the indications for naloxone for chronic opioid use come from the CDC guidelines for non-cancer pain. So it's a different, I would say, different patient population. But I do think more so than the prescribing of the naloxone itself is maybe more of a conversation and about overdose risk and maybe it's not that you prescribe it for every one of those patients, but you at least like in your initial and kind of follow-up conversations talk about what an opioid overdose looks like, how someone should call and get help, and would you like to have a medication in your medicine in your cabinet to have on hand just in case. But again, for those recommendations for the greater than 50 morphine milliequivalents comes from the guidelines for non-cancer pain. So I think maybe more of a conversations are the more, I don't know, that would add more value than just like, I agree, with, yeah, probably less value added to like automatically prescribe for every patient. Did that answer your question?
Yeah, thank you so
Perfect.
much.
And then I see a question about how much does Suboxone therapy usually cost? Yes, this is such a good question. So by law, federal law, Medicare, Medicaid, any insurance that is on the marketplace, like ACA marketplace, needs to cover medications for, needs to cover addiction treatment. I think what a lot of patients, basically like our uninsured, and then our patients who are on Hillsborough County healthcare plan, that county plan at this current time in March 2025 does not cover the cost of buprenorphine. So for those patients, we recommend they be seen, that they come to the van, and we have a grant that will cover the cost of their buprenorphine. But I think that, yeah, the out-of-pocket cost can be pretty cost prohibitive, like at least, 70 to $100 a month for someone on bup, like 8 milligrams a day, to like 1 film or 2 films a day. But yeah, for resources, I would direct them to the IDEA syringe services program, and we have resources for folks who can't afford their buprenorphine. And then there's, I would say, local advocacy ongoing for our Hillsborough County healthcare plan patients. Hopefully in the future, buprenorphine will be covered. Do you expect that potential reductions in Medicaid funding will affect the treatment programs you described? How are these programs funded? Great question about the mobile van. I wish Dr. Oxner was here since she's our medical director and could answer. I would say we have funds. We should be unaffected for the next at least the next few years, based on my understanding is. But yeah, the cuts to Medicaid, I can't speak to that. And I really worry about our patients who need Medicaid to afford their addiction treatment. I wish I had a better answer.
Okay. I think we got all the chat questions. Any other questions from those out there? All right. If not, we'll let you get back to your usual schedule. Hopefully you have 10 minutes to go outside and get a breath of fresh air. Beautiful, beautiful day. So Dr. Sarah Burbank, thank you so much. Excellent talk, and welcome again to our Department of Internal Medicine faculty. And we look forward to many, many years of great accomplishments. And thank you again for this wonderful talk.
Thanks all. Please email me any questions.
Thank you so much. And remember, everybody, your CME code is embedded in here. Thank you.